Okay.
It's up to you. It's like, it is recorded, so we can share later, but we'll see.
We can start so that you don't run out of time, right?
Sure.
Okay. I think people came right now. Yeah, we're gonna have an empty room. All right, well, we're just gonna go ahead and get started. This is Malia from ECHC. Hi, everybody on Zoom, and hopefully some of our ECHC folks will be coming shortly. Thanks for joining us today for this special Lunch and Learn created specifically for ECHC and Del Norte. For those of you who are here on site at ECHC, there's a bunch of food up here, so please join us in eating together. And then for those joining virtually, thank you, and feel free to eat your lunch while you listen. Today we have Dr. Michael Mangajas and pediatric NP, or nurse practitioner, sorry, Constance Mitchell, presenting on screening for adverse childhood experiences and evidence-based interventions for addressing toxic stress. The background for this is that this year, Open Door and First Five of Humboldt and Del Norte counties, as well as Partnership Health Plan of California, received a statewide practice grant to address adverse childhood experiences and toxic stress in our communities. The grant will help us better link arms to increase workforce and strengthen services for vulnerable children and families. In order to provide the best care to our patients, we need to evaluate for, treat, and understand how toxic stress affects our patients. We're here today to explore Open Door's commitment to screening for ACEs and what resources we have to support families in their healing. We're piloting these efforts at ECHC and Del Norte with aims to expand across the organization with future iterations of funding. We are so fortunate to have Dr. Mangajas and Constance serving as our medical champions for the practice initiative and help us improving our implementation of ACEs screening. A little bit about our presenters. Constance earns her doctorate of nursing practice and her master's of nursing pediatric NP degrees from OHSU in Oregon. She originally ended up on the North Coast to go to nursing school at HSU, where she completed her BSN. Fundamental to her practice in working with children and families is a vision where all youth are valued and heard for exactly who they are and where they receive the necessary resources and support to flourish. The focus for her doctorate was the implementation of the ACEs screening in pediatric primary care here in Humboldt County. Prior to her career as a pediatric NP, she worked as a public health nurse for child welfare services in the emergency response unit in Humboldt County, and she also served in Trinity County as a public health nurse. Her areas of interest include health equity, mental health, children with special health care needs, and addressing trauma in primary care. She's a founding board member for the Sorrel, sorry if I said that wrong, Sorrel Leaf Healing Center, a child and adolescent crisis stabilization center with intent of providing comprehensive care for the children of Humboldt County that are experiencing mental health crisis. She's currently serving on the state's Children's and Youth Behavioral Health Initiative, Equity Task Force, and the Alliance for Children in Foster Care and National Association for Pediatric Nurse Practitioners. Dr. Mangajas was born in San Francisco and raised in Mendocino. He went to UC Santa Cruz for college and earned undergraduate degrees in environmental studies and biology. He then attended the UC Berkeley UCSF Joint Medical Program for medical school with me, and went on to complete the UCSF Children's Hospital Oakland residency in pediatrics. We were fortunate that he and his wife Maya chose to move here to Humboldt County after residency to provide much needed care to our community. And since joining the ECHC pediatric family in 2018, Dr. Mangajas has been integral in helping to train our APC and family medicine residents in pediatrics, taking inpatient hospitalist call at Mad River Community Hospital, and of course, providing high quality care and complex care to some of our most vulnerable pediatric patients. So thank you all so much for being here and for your time today. And I'll leave it to you. Thank you.
Let's have a podium, so we should use it. So that was our title slide there. Before we started, we'd like to give a moment for everyone to settle in, grab some food for those who are here at ECHC. For those at Del Norte, there should be lunch provided to you as well. And if everyone would like to take just a moment to arrive and take some few deep breaths to center, if that feels great, then we have all the time for that. I'm sorry. know us, you've seen us, you know what we look like. For those who haven't seen us, this is usually what we look like. We have no commercial relationships to disclose. I'd like to take a moment to acknowledge that the land on which we are privileged to work and serve on is Wiyot ancestral land, and Humboldt County is the unceded territory and traditional ancestral homeland of the indigenous nations Behuba, Karuk, Matol, Olowa, Wailaki, Wiyot, Yurok, and the other original inhabitants of this land. So please join us today in acknowledging this fact as we meet here together. So the ACEs Aware initiative is a statewide initiative that was led by multiple agencies, including Department of Health and Human Services, the UCAN network, which is a consortium between UCSF, UCLA, and various of the UC institutes, as well as California. I can't read what that says, but there's other things, and it was led by a pediatrician named Nadine Burke Harris. And the ACEs Aware initiative goal is to cut ACEs and toxic stress by half in one generation. The way that we are going to achieve this is through a number of activities. And the first activity is always raising awareness of what ACEs are and what toxic stress is. So you're here today because we have a ECHC and Del Norte standardized training that we'll be sending you guys links to later on how to complete and how to test, and thanks to those who have already become ACEs Aware certified. In addition to the training we provide, there will also be protocols on how, as Medi-Cal providers and practitioners, we can bill insurance to help support the ACEs work that we're doing here. The other things that we'll be working on is a practice change. So we're also going to work to increase not only screening, but to increase workforce and support in our community to say, we have something that we can do if you're experiencing adversity. Some of the things that we're working on currently are embedding the screening into our electronic medical records, developing toolkits and algorithms, and more further trainings for all of the care teams. And then lastly, the way that we're going to cut toxic stress and ACEs in half is by developing something called a network of care, or a trauma-informed network of care. And this is about connecting us outside of the clinical setting to the community in which we work and live in, to help provide patients and parents and families with the care that they need to heal. So networks of care are essential to expand engagement around mitigating toxic stress, and we'll talk about what things are evidence-based to treat toxic stress. And we want to acknowledge that as providers, we can't really do all of this work here in the clinic setting. It has to be a community effort. Next slide, please. So specific to the practice grant, this is a statewide funding that we received $500,000 for just this year to increase the workforce and screening here at Open Del Norte and Open Door Eureka, and to sustain not only screening, but the response that we have to ACEs and toxic stress in our community. And how are we going to do this? Well, one thing that we're doing currently is working on strengthening our partnerships between community-based organizations such as Humboldt First 5, as well as Del Norte First 5. We're trying to identify what gaps in service exist currently and for our patients who are experiencing ACEs, and also to bring on new workforce types and services to fill those gaps. We're also partnering with our medical care plan partnership to leverage funds to address these ACEs so we can sustain them after this grant finishes. So this is a pilot. We're piloting universal screening, meaning we're piloting screening all children at both ECHC and Del Norte. And this is an iterative process. So we try something, we see how it works, we gauge our success, and we refine. We aim to create a toolkit and a system because we know that all of you providers are busy, so that we can make it easy. You don't have to reinvent the wheel. And we want this to be something that's built in and integrated into your workflow. And we want to leverage other experts across our organization to support families. So, training the MAs to potentially feel comfortable asking about adversity, asking the nurses to get the training too as well, so that they feel comfortable. So it's a shared language. This pilot and other data that we have gathered will inform the development of a toolkit, which we hope will come in kind of the winter fourth quarter of this year, so that we have standard operating procedures across the organization to implement screening, and also a standardization of referrals and how to bill for this. We aim to also identify champions, those who are interested in continuing this work. Currently, Constance and I are the champions, but the more champions and the bigger team we have, the more gold medals we take home. We're also working on developing a workflow for providers who see adults, because adults also experience adversity, and we want to capture and address that adversity as well. So whether you see kids or not, the grant funding that we have right now allows us to pay for administrative time for all providers at ECHC and Del Norte, whether you see kids or not, to complete the ACEs Aware training. And then we had tried kind of sending the training to everyone in the past, but without protecting your administrative time, we all get busy and we do work, and it's hard to add another thing to do. The other thing that we're doing is we're adding a admin code to payroll, and we'll send an email with instructions on how you can bill for those 2 hours. So it doesn't have to necessarily be done during clinic time, but there are some protected times that your site administrators have made and scheduled for providers to be able to take this training. Well,
So please bear with me. I have given lots of talks on ACEs, but I think this is the one I'm the most nervous about because it's with colleagues and that it's actually happening in the clinical setting. And so taking a look at our objectives today, we're going to discuss the barriers to implementing ACEs screening at Open Door and what our plans are on addressing those barriers. We hope that you'll be able to understand that addressing ACEs and toxic stress will help us prevent chronic health conditions and problems in our community, and understand that in order to provide the best care to our patients, we need to evaluate for, treat, and understand how toxic stress affects our patients. And we hope that you also become familiar with what is the available evidence-based treatments for toxic stress. And so first, we're going to take a look at some of the barriers to screening. We'll briefly review what ACEs are, what is toxic stress, and the science of adversity, and what the impact is to our health outcomes. And so it was interesting for me today to think that I am talking about 25-year-old research, because I remember when I first came across this research, and that was the 5-year mark, and then the 10-year mark, and the 15-year mark, and the 20-year mark, and now it is 25 years old, and we still have not figured it out. So the term ACEs comes from a study done in 1998, done by the CDC at Kaiser, and they found that there was a dose-dependent relationship associated with some of the most common and serious health conditions in our society, and that they were associated to 10 experiences that happen in childhood. And those things are classified underneath abuse, neglect, and household challenges. Now, keep in mind that the population of that study was mostly white, middle class, and privately insured. One of the pieces that's really important to recognize from this study is the risk factors for that toxic stress. And so those under the abuse category include physical, emotional, or sexual abuse, neglect, physical or emotional, and then our household challenges would be things like growing up in a household experiencing incarceration, mental illness, substance misuse, or dependence, or absence due to separation of a caregiver, or intimate partner violence. And so I know that we all are addressing the social determinants of health, and I just wanted to take a brief look at this and thinking about what they are. It's the conditions in which people are living, learning, working, playing, developing, right? And that it impacts a wide range of our health and functioning and our quality of life outcomes. So recognizing our social determinants of health as additional risk is important because they co-occur with ACEs, and they contribute to the prevalence and can exacerbate their impacts. It's also crucial to understand and be able to address ways in which these factors can compound the cumulative risk of adversity and reduce a caregiver's ability to provide a safe and stable environment for a child. So I also want us as a group to understand how social determinants of health, like access to healthcare, social and economical factors, and the ongoing and structural systemic racism and discrimination is impacting health and health inequities. And so that this is a place for us as healthcare providers to ask if we're further contributing to those inequities or if we're a part of the solution. And so a new way that this has kind of been thought of and changed is that we're looking at it more from the 3 realms of ACEs within our community, within our households, and within our environment. And so the 3 realms of ACEs have been expanded to include other adversities like racism, discrimination, poverty, historical and intergenerational trauma, climate change, a lack of employment, and substantial schools. And being able to identify these is then going to give us that way to address the toxic stress risk. So when working with patients, by having a larger view and a perspective of what's actually impacting their daily lives, then we're able to better understand how we can help support our families, right? To just say, be more resilient without providing any sort of support on how to be resilient is just going to further that trauma. And so we really need to think that we are a part of the shared responsibility in addressing this. So many of you probably are already aware of this. What do we know about ACEs in our community? So we know that about 61% of adults in the state have 1 ACE and about 16% have 4 or more. Now, the area that we're the most concerned about is Humboldt County. And I often hear people say, we are one of the communities with the highest ACEs. And when you're done with this training today, I no longer want you to say we are one of. I want you to be able to say we are the highest rate in the state, because that's the fact. We know that 75% of our residents have 1 or more ACE, and that 30% have 4 or more ACEs, which is almost double the rest of the entire state. So previously, when I first started doing my work on ACEs, we had no data on children. We now understand that about 30% in our community have experienced 2 or more ACEs, and that the children of our community have the highest rate of ACEs in the state. So we're not one of the highest, we are the highest, right? And so we have a higher percent of children who are experiencing child abuse and neglect, reports of sexual abuse. We have the highest rate of children who are in foster care. We have a higher rate of homeless public school students. We have a higher rate of living at or below the poverty line. And we have the highest rate of domestic violence compared to California as a whole. So keeping in mind that we know that there's an association of ACEs and negative health outcomes, I also want us to keep in mind that our numbers do not determine the individual's destiny, that there is a point of intervention. And also to highlight for Del Norte County, they also had limited data. Big problem with that is our N number, right? It's hard to get a population for significance. They have a higher rate of children in foster care. They have a higher rate of substance use, the highest rate in the state for domestic violence calls. And they also have the highest estimated need for mental health services in the state. And so taking a look at our ACEs associated health conditions, we know that there is an association between our ACE exposure and our health outcomes. And they include cardiovascular, pulmonary, immune, metabolic, mental health, and substance use conditions. And so while the relationship between ACEs and mental health outcomes is what we commonly think of, and in fact, that was shown in the survey that some of us feel like we should only be screening for ACEs when there is a mental health condition, the biggest ACEs associated health condition is actually related to cardiovascular health. And so in looking at ACEs, we know that each of them dramatically increase our risk for 9 of the 10 leading causes of death. And so they're listed all there. And so another interesting fact that I like to point out at this time is that just to consider that for every $5 that we as a country are spending on adult primary care, we're only spending $1 on pediatric primary care. And so the list, taking a look at the list of this, I'm sorry, you're changing for me. I totally forgot to go next slide. Thank you. I'm so good at that. I was like, what? I totally forgot that part. So when we're looking at our ACEs associated health conditions, you'll notice that the list will start with our medical and then go into our physical, and that the lower half of the screen is more focused on our behavioral and mental health symptoms. And so I've pointed out some of the bigger ones. Thank you, like our asthma, allergies, obesity, learning and behavioral problems. It can be harder for us to recognize those other things and not realize the association to ACEs. Like, how often do we associate ACEs to eczema? Not very often, but we have tons of literature and evidence that supports this. And so in taking a look at the adult conditions, we know that a person with 4 or more ACEs is 2 times more likely to have a stroke, 2 more times likely to have cancer, 1.6 times more likely to have diabetes. I do want to point out that there's an exponential increase for suicide risk, that's the one that it's not a 4 or more, it's for every additional ACE that you have, you are more likely to attempt suicide. So it's a 12.2 times more likely to attempt suicide. We're more likely to use injection drugs, and we're 7 times more likely to be an alcoholic. In addition, something to just keep in mind is that a person with 6 or more ACEs on average is going to have a life expectancy of 20 years less than somebody with 0 ACEs. So why is it that the things that we experience in our life, like parent incarceration, is going to decrease our quality of life? So Dr. Mangas is going to speak to the biology of adversity.
I love this part because I get to be really nerdy. So we're going to go through a lot of information and slides. I also wanted to point out that these slides will be available later as recording, and so you can review a lot of the data. So this is the image demonstrating how our body can respond to stress. So stress in and of itself is not a bad thing. There are some stresses in our lives that are good. Those we call positive stresses. And the way that our body is able to manage the effect of stress is that typically we have homeostatic processes that help us to ride out and buffer the stress. Usually when we think of positive stresses, we think of things like getting ready for a big game, studying for a test at school. There's a brief activation of our sympathetic nervous system. It's usually a finite period that goes away, and then homeostasis helps us to recover from that stress. Then there are stresses that we can tolerate, and there are different genetic and environmental factors that allow us to be able to have tolerable stresses. These are things where it might be a little bit more of a longer duration of a stress, but we still are able to mitigate the negative effects of stress because of the buffering effects of either our genetics and epigenetics, as well as the people in the community around us that help us to navigate this. So you can think of this as like a natural disaster. I'm sure all of you have had some kids that you've had to see that after the earthquakes were having some difficulty with sleep, and it's probably, maybe, hopefully now starting to get a little bit better. And then on the far right side, we see what's called toxic stress response. And so this is a physiologic response that is maladaptive, that happens when we're exposed to intense and sustained stresses. And this prolonged activation of our stress system prevents us from being able to use our homeostatic processes to get back to where we were. And this can be seen often with the ACEs that we experience. Next slide. So toxic stress response, I want to state, is a physiologic response. And there's consensus among scientific evidence that high doses of cumulative adversity experienced during critical and sensitive periods of early life development without enough buffering protection of safe, stable, and nurturing relationships and environments can lead to long-term disruptions of brain development, immune and hormonal signaling, as well as genetic regulatory mechanisms. So this is what we call the toxic stress response, is those changes in our physiology. Some of the risk factors we think of developing toxic stress are the exposures, the ACEs, and the circumstances and the conditions that have documented associations between increased likelihood or susceptibility of developing the toxic stress response and therefore developing disease because of the toxic stress response. All right, we're going to start at the top. So I want you to think of this as a little placeholder of how we're thinking about kind of the mechanism of injury, per se. So there are inputs coming in from our genes that may predispose us to having increased risk of toxic response in response to adversity. And there are protective factors also from genetics and our family and other community members that help mitigate how those inputs of adversity are going to affect us. But in the situation where the balance is tipped off and the effects of adversity outweigh the buffering effects of our epigenetics and protective factors, we see dysregulation that is chronic in three main domains. Those main domains are in our neurodevelopmental pathways, in our hormonal and endocrine signaling, and as well as our immune system itself. There have been a lot of studies that describe some of the long-term changes. So if we look at our endocrine and hormonal signaling, you can see differences in those who have experienced adversity versus those who haven't, in changes in ACTH signaling, cortisol, adrenaline, and other hormones that lead to increased stress activation in the body and inability to turn off these stress responses as well. We've even seen changes in growth hormone, thyroid hormone, and pubertal and sex hormones, that changes in growth, development, and metabolism in puberty are also affected by adversity. We even see changes in leptin and ghrelin signaling that leads to increased risk of obesity and overweight. In the brain, we can see changes in actual neural pathways, and they demonstrated this on fMRI studies, that there can be overactivation in the hippocampus and amygdala that leads to increased fear response to otherwise not fearful stimuli. And we can also see inhibition of the prefrontal cortex. That's why if you look at the other ACE-associated health conditions, any kind of learning disability and ADHD is significantly increased above baseline when you have increased ACEs. And it's not even ACEs over 4, it's an ACEs of 1 or more does still slightly increase it. And then when we look at our immune system, which is really interesting, we see there's a dysregulation of the sympathetic nervous system that actually increases the risk of autoimmune disorders because our immune system becomes hypervigilant. And so then we also can see increased inflammation, increased blood pressure, that leads to why cardiovascular disease was the biggest driver when we see associated health conditions. And then it's not demonstrated on here, but this also leads to epigenetic changes. And we can see that adversity being experienced by a parent can be transmitted to their children as well. We can see things like shortening of telomeres, which is one of the things of leading premature death and altered cell repair, and cancer. This is a busy slide and I should have edited, but this is a demonstration of how the ACEs that a parent can experience leads to impact in their offspring, both in utero and postnatally as well. I'm not going to go through all the things, but there's different factors that that's kind of like, we didn't get here all of a sudden, right? Humboldt County has experienced adversity for many generations, and that's also part of the reason why it continues to be the highest in the county, in the state. On the right, there's this little telescope looking like thing. I want you guys to imagine that the gray cone on the inside is a child's ability to self-regulate, and the outside is a parent's ability to help that child regulate. And if we start with birth, what we can see is that infants are not really great at regulating themselves, right? They cry and oftentimes they don't know why, and we have to, as adults and caregivers, go through the steps of are they wet, do they need to eat? And so that's a process that we call co-regulation. And co-regulation is really important in the early stages of childhood. And as a kid gets older and turns into an adult, they develop internal self-regulation skills, and the need for co-regulation decreases. This is called the transactional model of development that was developed by Samaroff and Feast in 2000. Now, if we have an interruption in either the parent's ability to help with co-regulation due to adversity or household dysfunction, we can see that if we decrease the amount of co-regulation in the beginning, that infant may have also difficulty with developing their ability to self-regulate as well.
I'll try and remember the things, slide. Oh, good. So we're gonna take a look, and I love Play-Doh, feel free to play. Now we're gonna look at some of the barriers to implementing, and then how you can do this in practice. So it was interesting, when I first started out, I was only really able to find one piece of data locally, which had come from a report of providers trying to access mental health services for children in our community. And it found that 93% of providers had reported that they had difficulty accessing mental health services for youth specifically. Other barriers that have been reported in the literature to practice is having a limited knowledge on the original ACE study, a limited understanding on the need of how to do it or how best to incorporate into practice. And then other barriers that have been identified include the emotional discomfort that a provider can experience when screening for ACEs, which can be perceived as, this is too sensitive of something to talk about. I don't know how to approach this with a family. Other ones include providers' perceived organizational culture and system attributes to a challenge in performing the screening. Maybe there's not support from the larger system, or having a lack of clinical resources, or a lack of community supports that you could refer to. As a part of my project, I had surveyed all of the CHDP providers in the county, and some of the barriers that got identified locally was having a lack of mental health resources or mentorship programs for youth, or resources for implementing social supports in our clinical setting, something like case management or a parent coach. Another one was that organizational buy-in, and then resources specifically for families. And there was also a call for a need of a central point of contact or center that could include case management support for families. So why do we want to screen for ACEs? I think you'll hear us say it a lot. We want to identify it early, so that if there is a support that a family can need, that's somewhere that we can help be support. Another thing that I see clinically in practice with doing it is that it's holding the space for the family to be able to develop that relationship, that maybe they're not needing something from you, but you just heard them and they feel seen and not shamed. So we also want to increase our awareness of the relationship between exposure to adversity, stress, and those physical and behavioral health outcomes. We have an opportunity for health promotion from the 6 domains of wellness. And so there are some cards available on that if you want to take those and use those. We can also help support promoting stress reduction, and we want to make community connections to those other additional services when it might be needed. And another important part of why we want to screen for ACEs is that it's going to reinforce the role of the primary medical home as the appropriate and apparent place to seek support when you have an adverse life event occur. So we think that in combination of screening with the provision of anticipatory guidance, that in of itself is a powerful intervention. And so for our community, a knowledge of resources and community supports is definitely one of the largest barriers. And a needs assessment, I already talked about that. You can go ahead and change, sorry. And so what is the rationale behind it? What is the value in doing it? So we know that when we're screening for ACEs and toxic stress and providing those targeted interventions, that we're going to be able to improve the efficacy and efficiency of healthcare. We can better support the individual patient and the family's health and well-being. And we have the opportunity to interrupt those intergenerational transmission of ACEs or toxic stress. And we can ultimately hope to reduce those long-term healthcare costs. So I heard Michael say this yesterday and I really liked it. You might not be able to see what the cost benefit is today, but 20 years down the road, when none of us are here any longer. That's when we hope to see that benefit. And so other supports for screening of all patients is that we know that we have a high prevalence. There's a lot of health consequences associated with this, and all of those chronic health conditions cost a lot of money. So we have the opportunity to do that early intervention. And then we're able to early detect those non-neuropsychiatric conditions that are associated. And we can improve the patients being able to disclose, again, by reducing that stigma. So there's two tools that are available. There is the PEARLS tool that's used in the pediatric population. It's 10 questions on the front with an additional 6 questions on the back that look for specific social determinants of health. And then there's the ACE questionnaires for adults. There's de-identified and identified tools. It's really the provider's preference on which one they want to use. We do recommend to use a de-identified tool that a family doesn't need to disclose exactly what has happened to them for you to be able to have the conversations. And it's the total number of ACEs that have been experienced. It's not necessarily the frequency that these things have happened or the severity of what has happened. And so we have, and I passed it around for you, each of you, is that there's the algorithm that shows you what can you do. So the algorithm is able to help us assess whether a patient is at a low, intermediate, or high risk for toxic stress physiology, and then how to incorporate that screening into our clinical care and follow-up plans. Not everyone that scores positive is necessarily going to want some sort of support at that time. And I am having a hard time seeing it. So we have our low risk. We're going to provide that education, that anticipatory guidance. And then we have our intermediate risk, which can be a score of 1 to 3, maybe without an ACEs associated health conditions, providing that same type of anticipatory guidance, information on buffering factors. Maybe they do want a support at that time. And then we have our high risk categories. The 1 to 4s can be considered high risk with an associated health condition. And then a score are 4 with or without an associated health condition. And then, thank you. So we're gonna sending you a little reminder again of the neuroendocrine immune dysregulation. What are some of those ACEs associated conditions that can contribute to poor health? In practice, it's going to be hard to see beyond the behavioral and mental health issues. And the group is that by looking at it from which category does it fall into, that you're more easily able to identify, is that an ACEs associated health condition? So taking a look at the clinical response to ACEs and toxic stress.
So we want you guys to become familiar with what the evidence-based treatments are for toxic stress, because it can be really hard to feel comfortable asking about adversity if you feel like there's nothing you can do. And there is stuff that you can do. So toxic stress is amenable to treatment. And we now know that there are specific buffering skills and interventions that have been evidence-based to improve brain, immune, and genetic regulatory control of development, and therefore can intervene in those critical periods to help prevent toxic stress physiology. And then treatment of toxic stress in adults may also, like we demonstrated that there can be intergenerational transfer, help prevent transmission to infants and kids of parents. This slide, what can we do across the lifespan of a person? Well, we have to think about before what we can do. We have to think about like how we're going to have this conversation. And so a full clinical response has to take into account trauma-informed care, which we'll talk about and there'll be further trainings on. We want to think about some strategies that we can help put out the fire of what's happening when you're experiencing adversity. And again, we're talking about adversity in itself is not sufficient to cause toxic stress physiology. It's a balancing point like a teeter-totter. So if we can combat those adverse childhood events with buffering skills and help the parents learn about some strategies, they may not experience toxic stress physiology. And then we want to also promote safety and care coordination. We want to use a strengths-based approach to empower our parents to know that they already have a lot of the skills that they need to address adversity in their kids and in themselves as well. And I think about what I can do in my relationship with my patients before I think about the need to refer to someone else. And then, of course, we want to also think about the follow-up, and these may be multiple touch points, short conversations. It's hard to address all of this in one visit. This is Gabor Mate. I'm sure you guys know. If you don't know Gabor Mate, this is Gabor Mate. He has done a lot of work on trauma-informed care as well as kind of the neurobiology of adversity. And so trauma is not only what happens to us externally, but it's what happens inside of us, the physiology, the genes, our response. And when we think about what is a trauma-informed care approach, we want to bring a couple of core components to our approach to the family. We want to bring understanding, right? We want to understand that this is a common thing. So like we said, ACEs are common, and in Humboldt County, they're extremely common. You will encounter 7 out of 10 times an adult who's experienced at least one of these. We want to recognize and help our parents to recognize the effects of a trauma adversity on the health and behavior of themselves and their kids. And then we want to respond with what the best evidence-based practices are and integrate our knowledge of how trauma affects our patients. And if that is what's going on in front of us, right? A kid may come in for a concern that we don't necessarily think is trauma related, but when you ask those questions and have that conversation, that is trauma-informed care, to notice that that is something that may be in play here, not always. And then we want to be really careful and resist the temptation or the accidental re-traumatization of people. You know, we want to know that it may not be the right time to have these conversations. A parent may not necessarily want to have that conversation in front of their children. And so schedule and make space to ask, is this okay to talk about right now? And what we're doing here is shifting our lens from thinking about what is the medical diagnosis or what is wrong with this person to what has this person been through and how can I help them to either tap into their internal resources for healing or to provide them with a network of support that helps them to heal. One way that we can do that is think of the acronym HELP. So part of the language that we use, we want to bring hope, right? Trauma is treatable. It's not the end of the world if you've experienced adversity. Many of us here probably have experienced a lot of adversity, and here we are, medical providers in Open Door. We want to be empathetic, and we want to be careful in how we use our language, right? Words mean a lot. We also want to be loyal to our patients and recognize that the reason why we're doing this is because we acknowledge that it's important, and we acknowledge that in talking about trauma, we're going to be exceedingly careful about privacy and not share these things the same way we do with HIPAA. And we're going to also ask for permission, partner with our families, and develop a plan that is a discussion. We may not know what's going to best help our parents. They may know what they need help with, and we can partner and plan with them together. So I want to get into what are some protective factors that prevent the development of toxic stress. These are either intrinsic things or extrinsic things that help us to decrease the effect of adversity. Some of the intrinsic things that are important are things like our genes, our ability to regulate our emotions, and our ability to pay attention to things and learn. And some of the extrinsic factors are the buffering relationships that we have. So if there is household dysfunction, sometimes families have other family members that they identify that are strengths and sources of support. There are supportive environments that a child may be in, school, the health clinic, churches, other kind of religious institutions and things that they build their community from, and other community resources specifically that we'll talk about. These are the 7 evidence-based stress busters. So these are things that either when a family works together with their child or a clinician helps a parent to work on, they can help mitigate and decrease the risk of adversity. Briefly, starting in the top right, it's working on quality sleep, having balanced and healthy nutrition, exercise and physical activity, mindfulness-based stress reduction practices, ability to experience and have access to nature, mental health care, and then supportive relationships. I want to point out here that only one of the 7 evidence-based things is referral in and of itself, right? All of these other things are things that a family can work on without necessarily needing to be referred to other practitioners. When talking about adversity, we want to think about what the family is good at, right? So we assess what strengths a family can use to address those ACEs, because what that does is allows a family to continue to work on things when they're not here in the clinic, right? As providers, we're really used to prescribing a medication or making a referral to a specialist or doing a procedure to fix things. But trauma takes a long time to heal from. And so if we can identify what a family does well already, we can help build and support that so that they know that that's something that's actually going to help them out. We want to assess for relationships that provide these skills, and we want to assess for relationships of caregivers of the caregivers. So sometimes there's a really great grandma that's helpful in teaching a mom how to employ some of these skills. We want to notice how the parent and child dyad interaction is in the clinic and provide positive reinforcement, something as simple as saying like, you're a great mom. I just saw how Billy, climbed on your lap and you comforted him in this kind of scary clinic environment that we're in. And then we want to offer some of the psychoeducation on how kids develop and how that can be affected by adversity. And then one of the things that's really important too is after asking about ACEs and adversity and toxic stress, we want to ask, what are you concerned about, right? What is it that the parent at this time would like to focus on? And that's where we should direct our kind of chief intent. I'm just going to leave this here. We're not going to go through it as much. Motivational interviewing is a whole field of science. These slides will be available later. This has some scripting and some ideas of how we can have those conversations. Next slide.
So some of the resources that we have available to us, I'm going to start with. Thank you. So our internal resources, I know that all of you are aware that we have member services. We're serving both Humboldt and Del Norte County, and you don't have to be an open door patient to access this. They can help with Medi-Cal applications, Marketplace, CalFresh, and other services. They also are administering a number of programs that support community wellness, such as our community gardens and our Latino health coordinators. We have case management on site with several case managers that are available for providers and clinicians to refer to for things like care coordination, resource connections, transportation, housing, and it's an extensive list of services that they're able to provide. We also have our integrated behavioral health team members who can provide short-term services as a part of our whole person care. And I think it's quickly become a part of our standard of practice to refer to them. And they're available at both Del Norte and the Eureka site. And then I know all of our professional organizations have a different ideal of this, but team-based care is really a strength that we need to tap into. We are already doing it in a lot of ways. And when we allow people to practice to the full scope of their license, we're able to support our patients and families more. And looking at this type of approach, we can decrease the amount of replicated services and improve our quality of care. And another concept of team-based care that is pretty cool is that it's really focused on what are the patient's goal at all intervention points. Next slide. We also have a lot of community resource hubs that you might not know exist. So we have the Humboldt Community Resource List, which is a pretty exhaustive list. It was updated during the pandemic. And then we also have the North Coast Resource Hub, which is done through the North Coast Information Exchange. And we have our Humboldt Network of Family Resource Centers. We have 16 FRCs. Then they all have a huge capacity. And then a really interesting program I just learned of was Early Ripples, and that's a program that's run through the Cal Poly Early Childhood Education Department. And they also keep up a resource list as a part of the work that they're doing and also as a part of the Community ACE grant. So other community resources that we have available, one is public health nursing. They do prioritize children and families. They provide home visiting and case management with an individualized service plan that's focused on health and safety. And then we have the Nurse Family Partnership, which is an evidence-based home visiting program for first-time mothers. And they provide education and case management from the 28th week of pregnancy until the child's second birthday. For a lot of us, we think we have to refer to them by that 28th week of pregnancy. And I'll tell you from my experience, you don't. I oftentimes will meet with a first-time mom and a 2-month-old, and I'll call public health and say, will you please take them on NFP? That is the way that this mom is willing to do it, and they'll be more than willing to accept them. Another great resource is our play groups. And this is probably the most common resource I refer to for the family that has no social supports locally, might not like other people and has no mom friends, but isn't really sure what they're willing to do. And so I'm able to often sell Playgroup as a great free activity that has a developmental specialist, that maybe you can meet other moms that you like, and they have lots of trained staff of learning how to support that mom or father, because there are father-based playgroups, to bring them into a fold. Other resources are, I think we've identified that mental health is one of our biggest challenges. And so we can always refer to Children, Youth, and Family Services. Currently, right now, they're only accepting based upon levels. And so they'll take a level 1 or a child that's in foster care. But with the implementation of CalAIM, that's going to be changing. And anybody should be eligible for a service, whether they have a diagnosis or not. And then we have our Humboldt Bridges to Success program, and they work with local public schools to provide short-term school-based mental health interventions. So it includes a crisis clinician and a parent partner that helps them to develop that long-term plan. And then Beacon, now known as Carelon, is who administers BH support through partnership. I will say, in my experience, giving the parent the number is the least effective way to make the connection, and that I prefer to actually complete the Carelon referral form. I know our member services team will send a letter, but oftentimes families are going to tell us, yeah, I got a letter and I threw that away. And then for private insurance, that's probably the most challenging to access, but we have Enchant, the North Coast Mental Health Association, and then oftentimes families are told to go to Psychology Today. But if any of you have tried to find mental health resources through Psychology Today, we know that most providers are not accepting new patients. And so that's where I will try to then do that internal referral to our BH team. Additional resources, and there's an entire list from OCHIN that I printed out for you guys that I would recommend. The biggest one is actually the UCSF CAP program. And so that's the Child Adolescent Psychiatry Partner. And you can call them and do a consult on a patient, and they will give you their recommendations. I have been able to get them to accept patients in extreme cases, but I haven't seen that happen in a really long time. I also,
Nope.
no, it's both, yeah. And then I highly recommend the book, The Deepest Well by Nadine Burke Harris. Oftentimes I'll give copies of that book away. Healthy Steps is a great program on early intervention for children. And a movie I would recommend for all of you guys is Paper Tigers. And then this is where I get really corny. So I think that has an animation to it. It was the Helping Hands was a community project that got done at one of the Children's Mental Health Summits. And it asked everybody that was participating is, how are you gonna help with this, right? And so we know that the health of our community is really dependent upon our children. And it's something I find myself reflecting on as a lot, especially as why has it taken so long for our community to acknowledge how we've been impacted by toxic stress, when we know that both adults and children are the most impacted in the state. And are we waiting for someone else to come and help us save the day? Or is this our responsibility as primary care providers to start having this conversation? And ultimately, I guess I always kind of leave this as an open-ended question. And so I hope you take it with you and reflect on it. Is the reason that we don't address ACEs in our community because of an inherent bias and prejudice that we have in our healthcare system? And are we ready to change that now? So thank you for your time today. And if you have any questions, discussion points, or ideas, we would love to hear them. And if we don't have time for that today, you can also email those to both of us. Thank you.
We also have a parking lot if you feel like you want to write a question and you don't want to email us, and we'll address those too.
We do have just a couple of minutes for questions if anybody has any comments or things to discuss.
Has anybody gotten started on their ACEs Aware training? Yeah, don't forget to turn in your attestation forms.
I'm just gonna scroll through the universe and see if there's questions coming from anyone else out there.
Everybody here, Ashley has went ahead and actually blocked 2 hours for you to take the Becoming ACEs Aware training. So we'll send a guide out to you all how to access it. And you have dates already scheduled in your calendar. So probably have seen them, but those will come out again.
Oh, yeah, and then I see there are some providers who are not from ECHC or Del Norte. We're hoping to roll it board-wide soon, but currently we only have in the grant administrative time blocked off for ECHC and Del Norte providers. But thanks for coming.
You can still take the training.
Yeah, you can still do the training.
Awesome.
Thank you, everyone.
Thank you.
I guess one question is just like, what's next, you know, so we did the training,
Mhm.
all of us are doing the training.
Yeah.
I didn't necessarily feel like there was a clear, here, the tool to now use in clinic, you know, and I'm an adult provider, of course, but like.
So the ACEs tool for adults is embedded in Epic already.
Okay.
There are some doc phrases and templates that are usable in other service areas that we haven't added yet. We're working on developing one in PEDS, and the hope is to start just screening PEDS first, and then from that inform workflow for adults. There will be a study that Constance and I are participating, where it's going to be an implementation study where we have someone actually go through workflow with us. And the way they're going to have it done is the MAs are going to be administering a questionnaire at